Good afternoon to everyone. We still have a few people logging in, so we're going to give them a bit of time to settle in, and then we'll get started with our webinar for today. Thank you. Okay, I think we'll get started. Good afternoon to everyone. I know it's been a very difficult couple of days in Ukraine. I hope you're not having trouble connecting to our webinar, but thank you to those who have joined us. Our webinar today is titled Managing Acute and Chronic Pain in Children. My name is Dr. Miroslava Romach. I am a psychiatrist and co-director of the Ukraine Pediatric Fellowship Program, which is situated at Sick Children's Hospital in Toronto, and I'll be acting as today's moderator. This webinar series is an initiative, the Ukraine Pediatric Fellowship Program, a program supported by Sick Kids Hospital to improve the quality of pediatric healthcare in selected children's hospitals in Ukraine. The series was organized in collaboration with our Ukrainian colleagues as part of our efforts to provide ongoing pediatric physician training while recognizing the difficult and unique circumstances within Ukraine's healthcare system today. Just a few housekeeping slides to get us started before we start. Today's webinar will be recorded, and we will make the recording available on YouTube for those who are unable to attend the series live. There will be live interpretation between English and Ukrainian. Just click on the interpretation button at the bottom of your screen and click on the language that you would like to hear the talk in. If you wish to hear the interpreted language only, then click the mute original audio. And you can ask questions anytime during the presentations using the question and answer function, Q&A function on your screen. We'll try to get to as many of the questions to the speakers today as possible. And those we don't get to, you can direct towards Laura Lewis, whose email is in the chat, and she will try and return with responses to you. So I'm pleased to begin our series of presentations today. We have three speakers, Dr. Fiona Campbell, Dr. Lisa Isaac, and Dr. Carol McNair. I'll provide a brief background note on each of them, and then we'll begin with the presentations. Dr. Fiona Campbell is professor in the Department of Anesthesiology and Pain Medicine at the University of Toronto, and at SickKids, she's director of the Chronic Pain Program in the Department of Anesthesia and Pain Medicine and co-director of the SickKids Pain Centre. Fiona is a former president of the Canadian Pain Society and was co-chair of Health Canada's Canadian Pain Task Force, which in 2021 published an action plan for pain in Canada. She was also on the steering group that this year launched the world's first pediatric pain management standard. Dr. Campbell received the 2022 Distinguished Alumni Award in Science from McMaster University, and in 2023 received the Canadian Pain Society Distinguished Service Award. Dr. Lisa Isaac is a pediatric anesthesiologist and pain specialist in the transitional and chronic pain clinics at the Hospital for Sick Children. She's the medical director of the first transitional pain service for children in Canada. She's the pediatric pain fellowship coordinator and developed a curriculum to train both pediatricians and anesthesiologists, becoming the first pediatric pain fellowship in Canada to do so. She's currently on the executive of the Ontario Chronic Pain Network, where she's a key proponent of an initiative to increase access to and equalize pain care across the province. As the Director of Equity, Diversity and Inclusion of the Department of Anesthesiology and Pain Medicine at the Temerty Faculty of Medicine, University of Toronto, she's actively involved in wide-ranging initiatives to pain prevention and improved management, opioid stewardship, and improving equity, diversity, and inclusion for both patients and healthcare providers. And Dr. Carol McNair is a neonatal nurse practitioner in the neonatal intensive care unit at SickKids. She completed her PhD at the University of Toronto. In her role as neonatal nurse practitioner, she provides medical care to infants with complex needs and their families in the NICU. Over her 20-year career as a neonatal nurse practitioner, Carol has developed expertise in neonatal pain management, quality improvement, and nursing practice. She has published widely on various neonatal pain topics, and this is the focus of her research. Welcome to the three of you, and thank you in advance. We'll begin the presentation with Dr. Fiona Campbell, who will be presenting on reducing pain in hospitalized children.
Thank you so much, Miroslava, for that kind introduction. I'll just get my slides set up here. Oh, sorry, wrong view. Okay, before I begin, can I just check that you can hear me okay? Perfect, good. Diakiu, thank you for the kind invitation to speak on a subject about which I feel most passionate, which is preventing and minimizing pain for children. It's an honor to be with you today, but before I begin, I just want to acknowledge how very sorry I am about the war, and that last night was, the last couple of nights have been so difficult. My focus today is primarily on pain in hospitalized children, specifically on why this matters and how we can all do better. I have no disclosures regarding this presentation. I live in Toronto, which originates from the Indigenous Mohawk word tekaronto and means the place in the water where the trees are standing. I come with respect for the land that I am on today and for the indigenous and diverse peoples who reside here. I have no disclosures regarding this presentation today. And by the end of this talk, I hope you will be comfortable to explain why pain matters in children and describe system levels approaches for addressing pediatric pain management. I also hope that you'll be able to access resources to support implementation of pain strategies in your hospitals. I will also provide some practical tips for treatment. Pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This is from the International Association for the Study of Pain, and it is important to remember that pain is both a sensory and an emotional phenomenon. Pain can be further subdivided in various ways, for example, by underlying mechanism, but I think really most commonly by its temporal profile, and that's certainly how we've done that today. Acute pain is generally a symptom of tissue harm that is protective and resolves as tissues heal. Chronic pain, on the other hand, persists or occurs for more than 3 months, often years, and is not protective. This is a Ukrainian study. It is in adults, but the author's recommendations are very much relevant for children as well. They found that acute and chronic pain management is one of the most significant problems during the war in Ukraine. After war injury, the majority of intensive care unit patients have severe acute pain, and the majority of people with blast injuries and gunshot wounds will develop chronic pain. Importantly, the majority of these patients also developed post-traumatic stress disorder, or PTSD, and I understand that part of this webinar series is on the treatment of mental health, which is so important. We know that early effective pain management improves pain outcomes and decreases PTSD. And the author's recommendations are to standardize medical care and pain management at all levels of treatment, implement a multimodal interdisciplinary approach to pain management, maintain family and patient-focused education and personnel education, and organize acute pain services. So you will see in the slides that follow that this very much aligns with international recommendations for how to do a better job of pain management in children. I apologize that this slide is not in Ukrainian, but I like using this infographic to provide context, partly because I developed it and it's a slide with which I'm very comfortable. We know that acute pain in hospitalized children is common, often moderate to severe. It's undertreated, and it's a risk factor for chronic pain. Chronic pain affects 1 in 5 Canadians or people living in Canada, including between 1 in 4 and 1 in 5 children. And this is all compounded by lack of research and lack of education. In fact, a Canadian study showed that vets get more pain education than medical students. And this cartoon shows, sorry, I'd just like to show that cartoon. This cartoon shows that your dog can get better pain management or healthcare than you. It's a bit ironic. It's also a very expensive health issue. So my presentation is primarily on acute pain, and I'm talking here about moderate to severe pain. It's really not realistic to get pain down to 0, and I think we need to be able to accept that mild pain is okay. We need to focus our efforts on more significant pain. We know that for kids and families, acute pain is associated with suffering, with various complications, among which include longer recoveries, longer hospitalizations, unplanned readmissions to hospital, and the development of chronic pain and post-traumatic stress disorder. For clinicians, we fail in our ethical responsibility to do no harm if we don't do the best job that we can to mitigate pain. And in Canada, not treating pain is a violation of hospital policy and will lead us to not meet our accreditation standards. And again, for society, it is expensive. So very briefly, chronic post-surgical or post-traumatic pain is defined as chronic pain that develops or increases in intensity after a surgical procedure or trauma that lasts beyond the healing process for at least 3 months after the surgery or trauma. This again is a World Health Organization International for the Classification of Diseases, or ICD-11 formal diagnosis now. We know that chronic pain after trauma is common. It's disabling. Chronic pain is associated with pain-related disability. It has an impact on sleep, on physical and social functioning, and is a major impact on mental health associated with high rates of anxiety and depression. And in children, it doubles the rate of suicide. Chronic pain has significant economic impact. The cost of adult chronic pain in Canada in 2019, this is part of the work I did with the federal health ministry, was $40 billion. And importantly, one of the top patient-oriented research priorities for kids living with chronic pain is to prevent acute pain from becoming chronic. So we should really be doing the best job that we can of managing acute pain. So here's the thing. Despite substantial evidence to guide practice, children continue to have significant pain after trauma. Our challenge is to implement knowledge to provide safe, effective pain management to all children in the right place at the right time. That is, we need to close the knowledge to practice gap. Fortunately, we're at a tipping point. There is great international and national attention being paid to pain, and children's pain in particular. This will help lead to greater awareness, understanding, and action. Was born, and I will speak in more detail about this. In 2021, The Lancet published its Commission on Pediatric Pain, and in 2023, Health Canada published the first pediatric pain management standard in the world, which is aligned with both the Lancet Commission and the Child-Kind principles. Just looping back to the Lancet Commission for a moment, I wanted to highlight their 4 goals for pain, which are to make pain matter. And this will involve increasing pain awareness, implementing pain policies, creating pain committees. We need to make pain understood. That is, we need more research, education, and knowledge translation. We need to make pain visible. So we need to assess pain so that we know and have a diagnosis for pain when it's present. And we need better pain management. All right, so I'm going to focus my remarks now on recommendations from Child-Kind because it's an international umbrella organization. It's an international nonprofit whose goal is to make children's pain relief and prevention a cornerstone of compassionate medical care. Child-Kind promotes 5 principles which are written in Ukrainian on the following slides. Hospitals can receive Child-Kind certification if they meet these principles, and I'm proud that Sick Kids was the first hospital in Canada to achieve Child-Kind certification. You are not alone in trying to improve the way you do things for children's pain management. It's a problem across the world and, frankly, still in Canada. But there are resources to support all 5 of the principles of Child-Kind in the Child-Kind Resource Library. I know this because I'm chair of the Childkind Resource Library Committee, and I'm going to use the remaining time to explain the 5 principles of childkind and provide practical examples of how to meet these or achieve these principles. And I'd ask that you think about how these principles might be used in your own settings. So the first principle is that there should be an institutional commitment to pain prevention, assessment, and treatment. And examples of how you can do this include raising awareness of pain as a priority health issue. It's very important to get the buy-in of hospital leadership. And this was very transformative at Sick Kids when I began there I began there about 20 years ago, and I've been on this journey, and it's still not perfect. But until the leadership endorsed this as a health priority, it was really hard to make progress on some of the initiatives that we needed to do. So get yourself some colleagues in your executive offices, get someone to align with you and really help support your efforts. Think about establishing a pain committee. We have one at Sick Kids, and create specialized pain teams. You need acute pain services and chronic pain services, and ideally transitional pain services. The second childkind principle is that there needs to be education programs and awareness initiatives on pain for staff, trainees, and importantly, for patients and caregivers. The following slides include excellent, freely available resources for not only health professionals, but also some for children and families. This one is for health professionals. At Sick Kids, we created the online pediatric pain curriculum. It involves many pain experts in the authorship. It is freely available. It can be accessed anytime online via the QR code in the top left corner. And I've also included links on a slide at the end for all the resources that I mentioned today. The OPPC, or the Online Pediatric Pain Curriculum, is based on the IASP core curriculum for pain. And although these modules are only available in English currently, perhaps there's an opportunity to look at collaborations for translation, and also to say we create new modules fairly regularly. Project Echo for Pain is a wonderful and free educational resource, again, for health professionals, and again, created primarily by experts at Sick Kids. It is like a virtual rounds with short presentations along with case-based discussions. And you can see some of the topics that are covered. They're written in Ukrainian in the right-hand side of the slide. Echo sessions are usually at noon Eastern time on Fridays. So in Ukraine, you could spend your early evening joining in, perhaps with a glass of wine or a beer. We have people joining from around the world. Children and families also need education for managing pain. This resource was developed by our pain experts and exists on the Sick Kids About Kids Health website. There are major sections on acute pain and one on chronic pain, and each section is broken down by age range. Again, it's not available in Ukraine, although it is in several languages, and perhaps we could work on a collaboration to get this translated. I did find this education for kids and families in Ukrainian, created by the MEG Foundation, which is a highly trusted organization out of the United States. Solutions for Kids in Pain is a Canadian national knowledge mobilization network on a mission to improve children's pain by mobilizing evidence-based solutions through coordination and collaboration. Resources on pain management for caregivers and families can be found here as well. Some resources are in England and some are in French. The third principle is that hospitals use evidence-informed, developmentally appropriate processes for assessment of acute and chronic pain. If we don't have a way of measuring and documenting acute pain, then how can we know whether our treatments are effective? At Sick Kids, our policy states that every patient will have pain assessed and documented using a developmentally appropriate, reliable, and valid measure. I'm just going to highlight the 4 that we use that are used for different age groups. So the FLAC Revised, which stands in English for Face, Legs, Activity, Cry, and Consolability, can be used for cognitively impaired children and also children older than 2 months. The word scale can be used. The FACES Pain Scale Revised can be used, and also the numeric rating scale can be used, which for older children I like because it's easy. If 0 is no pain, 10 is the worst you can imagine. What number is your pain right now? The 4th principle of Childkind is that hospitals use specific evidence-informed protocols for pain prevention and treatment, including pharmacological, psychological, and physical treatments. Examples of each will be in Ukrainian in the next 3 slides. For pharmacological treatment, for pain prevention, in Canada, we promote the use of numbing creams for any IV or skin-breaking procedures such as phlebotomy or taking blood and IV starts. As an anesthesiologist in the operating room, we use acetaminophen, or paracetamol, I don't know the word that you use in Ukrainian, and non-steroidal anti-inflammatory drugs, opioids, and regional blocks when indicated for nearly all of our cases. And postoperatively, we use the same medications. Sometimes we use adjuvant medications that you can see in the table here, but these are more for neuropathic or chronic pain. Physical strategies include things like positioning, cool packs, heat for muscle tension, rest, modified movement, massage, focused breathing. And psychological strategies include education and preparation before painful procedures and surgery. I can't emphasize how important managing expectations is for kids and families. The use of age-appropriate distraction, imagery, guided imagery, therapeutic art, music and play, cognitive behavioral therapy, virtual reality, hypnosis, and breathing. So it is more than just about the drugs. And the final Childkind principle is that there is regular institutional self-monitoring within the framework of continuous quality improvement. We keep this quite simple at Sick Kids, but it is part of what we do. We monitor pain assessment documentation on all the inpatient units. We measure the prevalence of moderate to severe pain, and we also measure whether treatments were given when moderate to severe pain was present. So the last couple of slides, there are resources to support all the 5 principles of Childkind in the Childkind Resource Library. Modern technology such as Google Translate can be used to translate some of these policies and practice guidelines into Ukrainian. Here are some of the links to the resources I presented, and I'm very happy for these slides to be available for the audience. In summary, pain harms children's brains and bodies. It's traumatic for families and health professionals, and it costs the healthcare system time and money. Childkind provides a framework and resources to help organizations address this important health issue in a systematic way. And resources already exist to support better pain management for children and families. Дякую. Thank you.
Thank you, Fiona, for an excellent overview on the topic and for your willingness to share your presentation with everyone. So now we'll move on to our next presenter, Dr. Lisa Isaac, who will talk on the prevention and treatment of chronic pain in children. Lisa?
Good evening. And thank you to the organizers for having me. And particularly thank you to the audience today for joining us this evening. I will be exploring strategies to prevent and treat chronic pain in children. Next slide, please. I have no conflicts of interest related to this presentation, and I will not discuss brand names of pharmacological therapies. Next slide. My objectives are, by the end of this presentation, I hope you will have reviewed the incidence of chronic pain and chronic post-surgical pain in children, and that you will be able to list factors associated with chronic post-surgical pain and describe mitigating factors for chronic pain and chronic post-surgical pain. I plan to describe the evidence and around pharmacological and non-pharmacological prevention of chronic post-surgical pain, and then we'll compare the prevention of chronic post-surgical pain with the treatment of chronic pain. Next slide. So let's begin with ensuring that we're all on the same page using the same definitions. So you heard Dr. Campbell to talk about the definition of chronic post-surgical pain, which occurs following a surgical procedure or tissue injury or trauma, but it persists beyond the healing process. So this is usually at least 3 months, and by definition, it affects the patient's quality of life. Importantly, other causes of pain are ruled out, such as infection or failure of hardware. Next slide. When we think about chronic post-surgical pain, we might wonder why this is important when it really is only one type of chronic pain, and only in children. First of all, it presents an ideal opportunity to consider where it might be possible to intervene before pain becomes chronic. Even in those experiencing physical trauma, such as motor vehicle accidents or blasts or burns, there may be an opportunity to intervene early in the course of the development of chronic pain. So how else is it really important? We know from a systematic review and meta-analysis by Dr. Brittany Rosenblum and colleagues that the median prevalence of chronic post-surgical pain was 20% across studies. And there is increasing evidence that this incidence may be even higher, and particularly higher in trauma and burns. In adults, a 2015 survey of 11 European countries showed a 35% incidence of at least some pain 1 year after surgery, and 10 to 12% with severe pain and disability. Although the literature is a little bit different for the post-trauma and burns, we do know that it is equivalent to the post-surgical pain literature. In children, we also know from Dr. Rosenblum's meta-analysis that the pre-surgical pain intensity, which would be obviously relevant for trauma and burns, as well as child and parent psychosocial factors predict chronic post-surgical pain. Next slide. So if we look at the incidence of chronic pain generally, we see that the incidences are actually quite similar to the risks of chronic post-surgical pain. So Dr. Campbell reviewed the incidences of chronic pain in children, but I'd like to highlight again the incidence of disability. So we know that at least 1 in 5 adults suffers from chronic pain, but 10 to 15% of those have moderate to severe disability associated with that chronic pain. And while in children, the incidence is approximately the same as in adults, 1 in 5 girls with chronic pain have a high disability, and nearly 1 in 10 boys have high disability. There's not just greater disability in girls, but also a greater incidence reported in a few landmark studies. So we know that it seems to affect girls more than boys, but it's unclear why. In 2020, the World Health Organization studied the incidence of chronic pain in children across many countries with the Healthy Behavior in School-Aged Children study, and this showed 44% of adults reported chronic weekly pain in the last 6 months. Age and sex predicted pain, but patterns and pain locations varied from country to country. Next slide. So in this model, we can see that emotions and cognitions, such as belief systems or thoughts, may alter pain processing and activate the peripheral and central nervous systems, and then be associated with chronification. And we also know that parent and family may influence these factors or directly influence pain processing and the process of chronification. Biologic factors may also be interdependent with some cognitive and behavioral factors. and maybe behaviors, we can decrease peripheral nervous system and central nervous sensitization, perhaps with medication maybe, or with psychological therapies, or at least minimize it. And we can try to alter pain processing to break the cycle. This is analogous to the mechanisms of non-surgical chronic pain, where emotions, cognitions, behaviors, and parents and families influence the development of chronic pain. So let's talk about some of these risk factors as they pertain to the perioperative journey. So beginning with patient-related pre-surgical factors, such as demographic, genetic, epigenetic, and existing medical conditions that may all be relevant. So as we've discussed, we know that older children and females generally have higher rates of chronic pain, but there's minimal good evidence that either age or sex or socioeconomic status affects chronic post-surgical pain. In adults, we know that genetic factors, such as structural DNA sequence variations, for example, the catechol O methyltransferase gene, may be relevant to pain development, suggestive of inter-individual differences. Surgery and injury can lead to increased methylation of mu1 opioid receptor genes associated with persistent pain at 2 to 3 months postoperatively. And DNA methylated positions in GABA receptor and dopamine pathways related to pain is also associated with chronic post-surgical pain. In terms of the medical factors, preoperative pain, and most studies focus on pain intensity, is associated with chronic post-surgical pain, but it's unclear whether or not this is because pain is predicting pain, or maybe there's another factor. So really, we need much more comprehensive assessment of pain characteristics, not only pain intensity, but pain distribution and location, pain quality, pain sensitivity, and this should be further explored. Very little is known about other medical factors, except, for example, neonates in the neonatal intensive care who experience high amounts of painful interventions such as surgery, and they appear to have a higher incidence of significant pain and disability, as seen in the Epicure UK cohort reported by Dr. Sue-Ellen Walker. Nevertheless, in this cohort, the overall pain incidence was not different in the early preterm cohort compared to controls. So we clearly need deeper phenotyping and genotyping of patients to better understand the role of patient factors in the transition from acute to chronic pain. Next slide. So other pre-surgical factors that have been shown to affect the incidence of chronic post-surgical pain are youth pain catastrophizing, youth functional disability, and parent anxiety sensitivity, or the fear of anxiety, or of parent general anxiety. We'll discuss these in further detail as we go along. Next slide. So post-surgical factors in hospital, we know that acute postoperative pain intensity is associated with chronic post-surgical pain. And of course, this is a very important area to address. However, 2 studies have showed opioid consumption as a risk factor for chronic post-surgical pain. We don't really know if this is a proxy for pain or if it's the opioid consumption itself. Conflicting studies showed neither cumulative in-hospital opioid consumption after spinal fusion surgery in children, nor regional anesthesia, including neuraxial blocks such as epidurals or intrathecal or spinal anesthesia, had any influence, unlike in adult studies. So it's really unclear where this leaves us. Once at home, the subacute pain intensity is also associated with chronic post-surgical pain, another area for potential influence. Next slide. So I looked again to the literature to see what psychological interventions there may be out there for perioperative pain. When we look at this slide, we can take all of the studies together, suggesting psychological risk factors or vulnerabilities in both the child and the parent predispose a child to chronic post-surgical pain. So we'll review those. Higher levels of pain-specific catastrophizing and pain anxiety are associated with acute postoperative pain intensity. It's unclear whether there's an association with longer-term pain outcomes. One study found a relationship between pain-related anxiety measured 1 week after surgery and subsequent chronic post-surgical pain. The majority of funded studies found no association between pain-related anxiety or pain catastrophizing measured before surgery and chronic post-surgical pain, but pain vigilance and fear of movement were also unrelated to persistent pain. There are novel lines of research pertaining to social factors contributing to chronic post-surgical pain, as well as the role of family, parents and siblings, and of peer support. The parent pain experience. Well, there's a higher prevalence of chronic pain in children where either or both parents had chronic pain. A recent longitudinal study of over 11,000 people by Dr. Vopel-Lewis and colleagues found that parent symptom burden, including the presence of pain, was a significant predictor of child persistent pain at 12 months. It has been shown that greater parental use of pain words when reminiscing about their child's experience of tonsillectomy is associated with more negatively biased pain memories held by the child, which underscores the importance of the family context for chronic post-surgical pain. Dr. Melanie Knoll is doing a lot of work in this area, specifically parent reminiscing style, and this is amenable to change. Though exhibiting a degree of caution and concern towards one's child is adaptive and appropriate, especially after surgery or after trauma, parental caring behaviors can become excessive and prolonged and ultimately create harm. We know that in children with chronic pain, parental overprotectiveness is reliably associated with greater functional disability. This prevents the child from engaging in activities considered risky or harmful and engenders lower self-efficacy. In terms of siblings, it's possible that in families where there are other children also requiring parental attention, there's a dilution of parental attention and reinforcement of pain-related disability, and hence the presence of siblings may be protective. It's also possible that a child might model pain behavior from his or her siblings, potentially increasing the probability of developing chronic post-surgical pain. We know that peer support is important in teens and has been associated with pain outcomes in pediatric chronic pain, another novel line of inquiry. So peer and sibling bullying is also a potential line of inquiry and not well studied as of yet. Next slide, please. So returning back to the specific surgical and or traumatic experience and remembering that as is well documented in the literature, issues such as anxiety, depression, catastrophizing, and preoperative pain levels produce additional risks for the effects of afferent nociceptive barrage on neural networks. These may be more easily sensitized or adversely affected by the surgical process. So we know that pre-surgical areas that have been studied have been baseline pain, as we discussed, and youth catastrophizing, as well as baseline parent pain catastrophizing. In terms of the surgery, we know in children that every hour increase in the duration of surgery is associated with an increase in the odds of developing chronic post-surgical pain 1 year later. And then in the acute post-surgical setting, post-operative pain trajectories and pain intensity are associated with chronic post-surgical pain and high analgesic requirements. Pain unpleasantness is also associated with chronic pain, so how patients feel they are bothered by pain, as well as parent pain catastrophizing. But there is some controversy about this. Also, most studies that evaluate chronic post-surgical pain do not evaluate disability or functional limitation, which is where the adult literature is moving and what we look at in pediatric chronic pain clinics in terms of outcomes. Many of the studies neither included a full biopsychosocial model of pain, nor a pediatric fear avoidance model of chronic pain. From a biopsychosocial perspective, youth factors such as genetics and epigenetics, sleep, anxiety, pre-surgical pain, and parent factors, and such as their cognitive appraisals of their child's pain expression and pain catastrophizing converge and lead to chronic pain disability. Conversely, when we think of resilience, this is an important area that can be capitalized on to use to help children prepare for or to manage pain. So looking at their factors that help them in their daily lives. Next slide, please. So overall, this is a summary slide of the transition from acute to chronic pain, not surgical, but in general, and we can see the overlap with chronic post-surgical pain. Next slide. And this diagram creates a visual outline of timing, events, and risk factors contributing to the development of chronic post-surgical pain with assessment and treatment to prevent chronic post-surgical pain, and this is in adults. A combination of assessment, because we know that education can shift pain trajectories in pediatric posterior spinal fusion, adjustment for biopsychosocial patient factors, and ongoing education and treatment options may be more effective in prevention. Next slide. So when we look at prevention techniques, well, medication it continues to be controversial. A meta-analysis exploring the use of gabapentin for post-surgical pain in adults concluded that although it improved the efficacy of opioids, as well as reduced the need for analgesic consumption and opioid-related adverse effects, it in itself was associated with side effects, including sedation and dizziness, which was important. And this is not ideal for the adolescent patient who ideally would also be focusing at school. So there are many studies looking at gabapentin and pregabalin, and really the jury is still out about that. Ketamine clearly has been helpful for acute treatment of pain and also for management of chronic pain, but this continues to be an avenue for study. In terms of regional analgesia, there are adult studies, no pediatric studies, looking at the use of regional analgesia for breast cancer surgery and showing a reduction in the incidence of chronic pain for both breast cancer surgery and thoracotomies at 3 to 18 months. So this is really a potential avenue for intervention from a medical and perioperative level. Next slide. So when we, I don't think it's all been translated. I can't quite tell, but if we think about how we can then intervene, we can look at it from a structural point of view, and from a process point of view, and then from outcomes. So Dr. Campbell reviewed some of this, and I'll dive into specific details about how pain services, for example, can be involved, or you on a personal level can get involved at the hospital level. So you can look at legislation, standards in pain management, and quality improvement projects, as well as professional training, as well as considering specialist pain management involvement, or things like ECHO, as Dr. Campbell was mentioning. The processes that are important include the application of analgesic techniques such as regional anesthesia, pain assessment and documentation, and training in pain management. And then when we look at outcomes, this can then significantly improve physical functioning of patients, pain intensity during exercise, and adverse events. And we can also influence, therefore, patient self-efficacy by ensuring that we know what they need, and also by helping patients to have the tools that they need to improve their pain at the acute stage, and also at the subacute and chronic stages. Next slide, please. And next slide, please. So if we return to the factors that modulate pain, we don't have really excellent evidence around the medications, with the possible exception of regional anesthesia, which in models decreases neural sensitization. When we consider outcomes, there are really three main areas in which pain manifests: pain perception, so how people experience pain behaviors, or how they act when in pain, and pain-associated disability. So these last two are really important areas where psychological treatments can intervene, and sometimes in conjunction with physical therapies. Next slide. So what psychological techniques do we have? The prevention literature is currently quite squarely in the adult realm, although we are beginning to study and publish data around prevention in children. However, there is good evidence for the use of acceptance and commitment therapy, which capitalizes on the effects of acceptance. You'll notice as well that education is probably quite important for for prevention of chronic pain. This is specific education around the either surgical procedure or expectations for changes in pain over time. And but it's also very important to note that it's not just prior to the event, but also ongoing afterwards. This, as you can see, correlates as well with the psychological treatments for chronic pain. So we have a cognitive behavioral therapy, which has many studies showing significant good treatment outcomes using behavioral activation, reframing, catastrophizing, and more recently, trauma-focused cognitive behavioral therapy. And this has the benefit of being helpful for children who are less responsive to other forms of cognitive behavioral therapy. In the past, there was much more studying of biofeedback and relaxation, which we know is helpful certainly in the acute stages, and also is quite likely helpful for chronic pain management. And mindfulness-based relaxation strategies in particular have been shown more recently to be helpful for pediatric and adult chronic pain. Next slide, please. So here are two really nice studies that look at an overview of the studies of psychological interventions. So Davidson in 2016 reviewed 14 studies after screening 1,400, and the psychological interventions as a whole were helpful in the short term for pain in children. Very few studies looked at longer-term outcomes. Distraction and imagery was particularly helpful for the acute pain outcomes, but preoperative education and preparation was not on the subgroup analysis. The quality of the studies is low to moderate, and therefore it's really important that people continue to study this. And Nadinda in 2022 looked at adult populations, reviewing 21 studies after screening, and they found that interventions delivered after surgery and interventions delivered by a psychologist tended to be more effective than interventions delivered before surgery and interventions delivered by another healthcare provider. The interventions reduced both subacute and chronic post-surgical pain and disability. So they used CBT or cognitive behavioral therapy, acceptance and commitment therapy, psychoeducation, mindfulness-based stress reduction, and other psychological interventions such as expectation manipulation, pain management, relaxation, and guided imagery, and stress management training. Our group is currently looking at psychological interventions delivered preoperatively and reinforced postoperatively for children undergoing major surgery, and comparing this to preoperative preparation and education with postoperative follow-up and reinforcement. So the jury is really still out. Next slide. So when we think about how we can bring this all together, we think about what the ideal service for children to prevent chronic pain would look like. So this timeline comes from a series of design workshops led by Dr. Katie Burney in collaboration with multiple groups. So the groups included healthcare stakeholders, patients, parents, clinicians, including surgeons, psychologists, and anesthesiologists. It really delineates what this group of stakeholders felt was important when considering managing perioperative pain and the prevention of chronic pain. So the pain care team provides risk assessment, pain education, and development of an individualized pain plan. So for example, surgical specific pain management, setting of expectations, including physical strategies and activities. It importantly may provide cognitive behavioral therapy and or mindfulness and acceptance and commitment therapy with breathing and relaxation teaching, distraction planning, and practice of these techniques before surgery for postoperative pain management, as well as explanation around pain medications and opioid stewardship. Importantly as well, the pain management plan should be reinforced afterwards to optimize the subacute phase of treatment. So we understand that the treatments are quite varied and probably using elements from multiple different types of treatments. So not just cognitive behavioral therapy, but trauma-informed cognitive behavioral therapy and the other techniques that I've mentioned. Next slide, please. So when we consider the treatment process for children with chronic pain, we know that many children may be offered self-management tools, such as the Power Over Pain Patient Portal, a free online portal with access to information and evidence-based self-management strategies to help manage chronic pain. In more severe cases, however, referral to an interdisciplinary treatment group is critical for functional improvement, and we know that this makes a difference for recovery. In this case, an individual treatment plan would be created with access to group and/or individual physical and psychological treatments, as discussed, and they are offered with the addition of pharmacological therapies in select cases. The goal for this is discharge to self-management and oversight by primary and community care providers. Next slide, please. So, in summary, we discussed chronic post-surgical pain with preventive techniques in the pre, intra, and post-operative time periods with the evidence surrounding this, and compared to the treatment of chronic pain in children and adolescents. Thank you for your attention, and I'll pass this on to Dr. McNair.
Thank you very much, Lisa, for a very comprehensive overview on this topic that I'm sure will be very useful to our Ukrainian colleagues. And now we'll proceed to our final speaker, Dr. Carol McNair, who will discuss assessment and management of neonatal pain. Thank you, Carol.
Thank you. Can everyone see my slides okay? Yes?
Yes.
Okay, perfect. All right. Thank you for having me and inviting me. And I hope that you find the next session helpful as well. The object of my 20 minutes with you is to just talk a little bit about specifics and uniqueness of neonatal pain. Dr. Campbell and Dr. Isaac have talked about pediatric and chronic pain, and neonates are a unique subset of pediatric medicine where we need to manage and assess their pain a bit different. I have no disclosures to discuss. We need to understand that despite the neurological immaturity of all infants, the actual pain pathways and neuro and neuromuscular things that are needed to perceive pain are present in all babies, regardless of their birth gestational age. They actually have potentially more sensitivity to pain because the density of the nociceptive nerve endings in the skin in babies is either equal to or higher than adults. And even though myelination is not complete at birth, the nociceptive pathways in the brainstem and the thalamus that are needed to perceive pain are present at 30 weeks gestation, and even the youngest infants at 23, 24 weeks have the ability to perceive and respond to pain. This is really important because babies are exposed to pain no matter what health outcomes they have at birth or whether they are admitted to hospital. Normal newborn babies are exposed to routine painful procedures in the first 48 hours of life with newborn screening, vitamin K injections, bilirubins, and sugar checks. However, in NICUs, babies are exposed to an exorbitant amount of pain, with babies in NICUs being exposed on average in the most recent evidence to around 5 to 15 painful procedures per day. This is obviously heavily weighted in the first few weeks when they are the illest, but some of the procedures they're exposed to are things like heel lance, venipuncture, central lines, arterial punctures, lumbar punctures, intubation, and then NG tube insertion. There's been a recent publication that tried to intensify what the different procedures do for from a pain point of view for the things that these babies are exposed to. And you can see here that the threshold to treat is around mild to moderate pain. And then we need to make sure we're treating those procedures that cause moderate to severe or extremely severe pain. And we need to make sure that we're using evidence-based practices to make sure we're managing this pain. Why is this important, and why is the burden of pain that we expose these babies to it's because there is huge early and repeated consequences to being exposed to pain in the early months of life. Things like persistent behavioral changes, smaller volume in sensory areas of the brain in preterm infants have been found to be associated with the amount of exposure to pain. There's studies that show that there's reduced thalamic volumes in babies who have been exposed to multiple painful procedures. There's evidence that they can have widespread neuronal death if they're exposed. They have decreased pain thresholds. They can develop anxiety later in life, and they can actually develop a long-term sensory hyperinnervation. There's also evidence that the number of skin-breaking procedures from birth to term in preterm babies predicts lower cognitive and motor development. We know from evidence that babies who've been exposed to pain in the NICU have different reactions as they grow and become older infants and young children, and that demonstrates that they actually do remember, and they have different responses to routine things such as immunizations and possibly surgical procedures. And then the long-term consequences of hyperalgesia, needle phobia can sometimes be related to neonatal exposure. So we understand that pain is a part of neonatal care. However, we know that the pain can cause long-term consequences. So pain assessment is the first step of preventing that. There are a variety of reliable and valid tools that can assess pain accurately. I have provided a short list here, but this is not all inclusive. And some of the resources that Dr. Campbell talked about on the Child Kind website have other neonatal pain tools that you can utilize, but these are some of the more reliable and valid tools. The comfort scale, there's Comfort Neo, the neonatal infant pain scale, NIPS, is often well used. The PIP-R is a premature infant pain profile revised, which is one we use. And then the NPAS, or neonatal pain, agitation, and sedation scale, is one of the other ones that's widely used across the globe. We know that in studies that using standardized assessments improves neonatal pain management. And so I do want to move on and talk a little bit about what are the best strategies for neonatal pain management. So neonatal pain management can be described as both non-pharmacological or developmental strategies, similar to what Dr. Campbell talked about with the physical and psychological strategies. And these should be utilized for all pain management for things that cause minor to moderate pain. And then pharmacological therapies, which can include things like topical anesthetics and analgesics, need to be utilized for those procedures or things that cause moderate to severe pain. There are developmental sensitive strategies that are kind of behavioral, psychological supportive, and those can be utilized for a variety of painful procedures or pain management. Environment itself can be helpful in reducing the total amount of noxious stimuli that babies are exposed to, and encouraging babies to utilize their own endogenous opioid receptors and systems to modulate their own pain. But some of the behavioral strategies actually do block the nociceptive input up the ascending fibers. They activate their own endogenous opioid system, and some activate sort of an attention arousal systems that helps the baby modulate. So some of the research shows that these developmental strategies are things that have been shown to actually work in reducing pain for babies undergoing mild to moderate painful procedures. Some of these techniques are useful for any degree of pain, and others are only useful for mild pain. So things such as sweet tasting solution, sucrose, glucose, skin to skin breastfeeding are all equal and good for managing mild to moderate pain and needle pain, whereas things such as NNS, swaddling, facilitated tucking, and rocking and holding, although they do reduce pain, are not useful alone for managing things that cause moderate pain, such as needle pokes. So this chart just demonstrates that for needle pain, evidence supports that sweet tasting solution, breastfeeding, and skin to skin care are equal in preventing the pain from things such as ion injection, subcu healants, and venipuncture. The other strategies that are listed here can be used in addition to one of these three strategies to improve the baby's response to the painful procedure. But none of these strategies should be used alone when you're exposing the baby to tissue damaging or needle pain. However, something like NNS or holding or swaddling could be used for something that's considered non-tissue damaging, such as an NG insertion. Pharmacological treatment, which I mentioned should be utilized for things that cause moderate or moderate to severe pain, are all available for various different procedures or disease management or postoperative management. And so some of this evidence suggests that these things are safe and well utilized in managing pain in infants and neonates. So topical anesthetics are safe for one-time use in neonates for things such as IM injections, other skin breaking procedures, and should be utilized for when available. And then for things that cause mild to moderate pain where you might need analgesics, things such as acetaminophen or paracetamol would be useful in treating mild to moderate pain. And then when you're looking at severe pain, you need to look at opioids, and the evidence supports that the most pharmacological data for neonates is available for morphine or fentanyl. Fentanyl is excellent for procedural pain and things that may cause severe pain, and morphine is an excellent choice for postoperative or disease management. There are other drugs that can aid in the management of pain and sedation in babies, and I didn't want to spend a lot of time on it, but I didn't want to be remiss, but people often look at benzodiazepines as adjunct therapy because it can reduce anxiety and provide sedation. But we need to remember that midazolam, although is the most studied benzo in neonates, it does have significant concerns for neurological impacts, which I will touch on shortly. Dexmedetomidine or Precedex is a newer drug that is being utilized in many NICUs in North America. It can be used often for sedating babies who need cooling or HIE, who are undergoing therapeutic hypothermia, as it does relieve the shivering as well. And it can provide a tiny bit of mild analgesic in addition to sedation. And dexmedetomidine may be neuroprotective as opposed to neurotoxic. And so when we talk about these drugs, it's really important to remember that neurotoxicity has been shown in the literature to occur with the use of pharmacological agents in neonates. And so exposure to prolonged or repeated exposure to some of these pharmacological agents has been shown to show neuronal degeneration. It's been shown to decrease neuronal activity and impaired cognition in animal studies. And chronic exposure to opioids has shown that it can alter the brain opioid receptor, changing the sensitivity that babies can have. It disrupts nerve growth factor. It can cause long-lasting desensitization of to opioids, and it can cause long-term behavioral changes, cognitive deficit, and learning impairment. And all of these studies have shown that this is things that are seen regardless of other confounding factors that babies in NICUs may have. And you can see in these slides, there are studies that look at cumulative morphine reducing cerebellar volume, exposure of midaz reducing hippocampal growth, and that reduction in hippocampal growth is grossly related to reduced cognitive scores on the Baileys done in neonatal follow-up. And so this is really important to remember that although pain prevention is really important and exposure to pain can cause detrimental neurological effects, exposure to pharmacological agents can have similar detrimental effects. However, it does appear that single doses of these drugs do not have the same long-term outcomes, and a most recent study suggested that perhaps less than 7 days of exposure to any of these drugs is probably not harmful. It is chronic or repeated exposure that seems to be the problem. And then finally, if pain is present, so there is pain stimuli, it does seem to negate the neurodevelopmental detriments of the drugs. So I always think of it as if you have a lot of pain, the drug has a job, and so it does its job, provides pain relief, and there is no long-term side effect of exposure to that drug. However, in babies who've been exposed to drugs without pain, that is when we see the most detrimental things. So what does this mean practically? I wanted to provide you with some of the things that we can do to then improve and manage neonatal pain. So things such as taking the pain intensity studies and looking at the procedures that we provide and ensuring that we develop adequate pain guidelines that correspond with the expected pain severity of the procedures that we're doing. So things like lumbar puncture being extremely painful, ensuring that you're using things like topical anesthetic if you can, non-pharmacological positioning strategies, sucrose, soother during the procedure, and you may even consider utilizing fentanyl if topical anesthetic is not an option. And then ensuring things like intubation, arterial puncture are all managed appropriately, again, either with topical or analgesia. So in summary, I wanted to make sure we talked that good pain assessment in the neonatal population is how everything begins. And so utilizing a good, reliable tool to assess pain in your babies is the first step in ensuring pain management. Procedural pain management must occur. It should never, no procedure should go untreated if it's going to cause pain. But there are a variety of behavioral strategies that can be utilized that can help the baby regulate and continuously ensure that the baby is able to cope with painful procedures, and that non-separation of the baby and the parent is a very good way to improve pain management. Evidence suggests that parents being present during painful procedures can improve, one, the use of non-pharmacological pain management strategies, as well as allow parents to participate in providing comfort to their babies. And this is really important to ensuring babies receive appropriate pain management. Unmanaged pain in these babies should be a never event because we know that pain is very detrimental to their neurodevelopment. However, we also know that pain treatments, and especially opioids and analgesics and sedatives, can also impact these long-term neurological outcomes. And so this requires us to really think about what procedures and what we're doing for our babies need to occur judiciously. So making sure we're not using opioids when pain is mild or there is no pain. So for example, opioids for mechanical ventilation is probably not advised. And then we want to make sure we're using the right pharmacological agent for the right context. There's lots of times when analgesics are used, such as morphine, for sedation in our patient population. But if we need sedation, we should be looking at what are safe sedatives to use in these babies, which of course the literature is a bit sparse there, but dexmedetomidine may be something that holds promise if it truly is neuroprotective. And then making sure we use sedatives when we truly need sedation and analgesics when we really need pain management, and choosing the right analgesic for the right purpose. So fentanyl is a very good procedural drug, but you only need low doses. And then also morphine, which does provide sedation, is probably the best drug to utilize in the postoperative period or in disease management, where you need good analgesic along with some mild sedation. I want to thank you guys for inviting me, and I hope that this was helpful. And if you have any questions specific to neonatal pain management, I'd be happy to take them.
Thank you very much, Carol, for an excellent presentation on a very critical topic that I'm positive will be very useful to our listeners. So now we'll proceed to the question and answer portion of our webinar, and I'll ask Dr. Zoryana Ivanyuk to select the questions and read them out, and have the responses interpreted. Zoryana?
Ще раз доброго дня усім. Насправді дуже вдячна спікерам за
Good
надважливу
afternoon to everyone. Again, thank you to the speakers for the important information. We appreciate it. We have the questions available in English, so I will be voicing them as they are. Are you routinely using such pain monitoring skills as NIPE, NOL, and PAM? This is the question to Fiona Campbell.
Fiona would like maybe more information on the acronyms here to be able to respond properly. And I think this is from Dennis. So maybe Dennis could just type in what these acronyms are for. Fiona,
Власне, абревіатури є англійською NIPE, NOL and PAM.
These
Do you
are
want-
the English abbreviations, NIPE, NOL, PAM. These are the pain assessment monitoring tools.
Well, I'm sorry, I don't recognize them. So that either means that we don't use them, or maybe we use different acronyms here, even though you've provided them in English. I don't know, Lisa, do you recognize any of those? No.
No, I don't either. Sorry.
Or maybe.
Власне, доктор Сурков скинув посилання.
Dr. Surkov just copied a link.
I'll
Let me
open
just
that and have
open it.
a look. Yeah.
На жаль, я
Okay, this looks very interesting. I haven't seen this site before. Carol, this site, I don't know if you've pressed on the link, but it's really about neonatal pain assessment. The NIPE is the Newborn Infant Parasympathetic Evaluation. It's a way of measuring parasympathetic tone. We wouldn't use that, of course, in the operating room, but are you familiar with that in the NICU at all?
Muted.
You're on-
There we
you're
go.
on.
Yeah, I got it. Okay. I have heard of them. They're relatively new and not well tested. And there's not a lot of clinical use that I know of those two tools, but I'm very vaguely aware of them. But they're more physiologic monitoring. There are people who are working on things like, is there a way to recognize pain from physiologic parameters as opposed to behavioral? But it's not a fully, I don't know of anyone using them yet, but I can look more into it and find out.
Perhaps Ukraine is more advanced in these monitoring measures than we are.
Maybe it's
Yeah, for
possible.
sure. Yeah.
Також ми маємо комент до цього запитання.
We
що-
also have a comment to this question, which says these are the acronyms for the neonatal pain assessment.
Добре. Наступне запитання. Як
Next
часто
question, how often do you perform pain assessment in a standard post-op patient? So how often is this process required?
Thank you very much. We have a pain assessment policy which is available on the Sick Kids external website. I can put that in a minute, but which is overarching, and then you extract for the different populations. So for example, every patient at a minimum will have a pain assessment using a developmentally appropriate, reliable, and valid measure at the following times. And so after surgery, this would be every time the vital signs are done, so generally every 4 hours, more frequently if significant pain is present, and 1 hour after a pain treatment if a treatment has been given for pain. Thank you. Thank you for your question.
Дякую дуже. Тепер
Thank you
запитання.
very much. Another question to another speaker, as far as I can understand. How often do you use catheterization of peripheral nerves for pain relief?
I don't know, Lisa, do you want to take that one?
Yeah, I'll take that one. Thank you for the question. So we do single shot or one-time needle regional analgesia quite very frequently every day in our operating rooms. The catheterization will vary depending on the surgery and the expected duration of significant pain. So we do them regularly every week. We would use them particularly for lower limb surgeries. We use them, and occasionally for upper limb. We just don't happen in our hospital to have as much upper limb surgery, but we do use tap catheters, and we also use lower limb, various multiple different lower limb catheters. Some of them we keep in hospital and run them in hospital, and we use a system for short-term delivery of local anesthetics that patients can go home with, and we have a nurse that then calls the patient the day after when they go home and the following day to ensure that they don't have any difficulties removing the catheter at home, the parent, of course. So we do it regularly, and we use a combination of catheter types. Does that answer your question?
Дякую дуже. І в мене питання ще до третього спікера.
Thank you very much. And a question to Ms. McNair about the neonatals. What about Canada? What is considered to be the long-term use of opioids? Is it 1 day, 2 days, 3 days, 1 week? What is considered already the longer opioid application? Where is this threshold of the short application and longer application?
We use 5 days as short, so under 5 days is considered short duration, and then anything over 5 days we consider long. And if babies have been exposed continuously to opioids or sedatives after 5 days, we would actually take time to wean them as opposed to just discontinuing it so that they don't undergo withdrawal. Does that answer the question?
What would a typical schedule of weaning or tapering, what might that look like?
Yeah, we use a withdrawal scale called the WAT1. So we would utilize that, and we would wean 10% every 24 hours, assuming the withdrawal scores are low. This is iatrogenic withdrawal, so exposure in the NICU to the drugs, not to neonatal abstinence syndrome. So exposure in utero is different than exposure when you are post-op 10 days of age. And so we're very careful to make sure we monitor those differently.
Thank you.
Дякую дуже. І маємо ще одне. Перепрошую. Маємо ще одне запитання. Чи ви
We have
застосовуєте?
another question. Do you use the caudal anesthesia in the neonatals?
I didn't hear what the question was?
Caudal,
Sorry.
the caudal
Caudal.
anesthesia, yes.
Well, I would have to defer to the anesthetist for that. We don't tend to see it a lot, but I'll let Lisa or Fiona talk to that.
Yeah, I mean, we certainly use caudal anesthetic blocks in the operating room, typically for the babies who are going back to the neonatal intensive care unit if they've had abdominal procedures. If any regional technique is going to be used, it's more likely to be an epidural or a tap block or some of the peripheral nerve blocks. And they've not been in widespread use for many years. But it is something that we're trying to improve in the hopes of having earlier recovery after surgery and to reduce the amount of opioids that are required by the babies. Thank you for the question. Oh, and also just to say, I'm going to put in the chat a link to the opioid withdrawal policy that we have at Sick Kids.
Yeah, and that would be the one that we utilize as well. And I was just going to add that our most common regional anesthetic that we see post-op in the NICU is the tap blocks.
And I'll add that when we do use caudal catheters, we tend to use them in the slightly older babies. And one of the difficulties that we've had is in keeping them clean. So, so we've been reviewing whether or not we should be tunneling those catheters so that they're staying away from the diaper area, and different methods of draping them so that they stay clean, which is ongoing.
Yes, indeed.
Thank you. Any more questions from our participants before we end the series? If not, you have Laura's email if you wish to submit something after the completion of the webinar. I'd like to thank all of our speakers today very sincerely, again, for your time, for your excellent talks. We are very grateful to you for this. I'd like to invite today's participants to our following webinars, the remaining webinars. They will be held on March 26th. The next one at 4 p.m., the Cave time zone. The next three webinars actually will be related to burns care. And the first one on March 26th will be the psychological management of burns patients. And this talk will be given by Dr. Mark Hansen, a pediatric psychiatrist. If you haven't already registered, you can click on the link provided in the chat or on the QR code in this poster. And again, thank you to all of you for joining us today. We'll work together towards improving pediatric healthcare and making a positive impact on the lives of young patients in Ukraine. May you all stay safe, and we will see you at our next seminar. Thank you again, and goodbye. Дякую.
Bye.
Thank you very much for having us, Miroslava and Laura, for your help.
Oh, thank you.
Thank you.
Thank you so much.
Yeah.
Maybe we'll lasso you into some more of this in the future.
Sure.
Thank you again.
Yeah, anytime. Okay, I have another meeting at 12:30. So thanks
Yes.
to all of you.
And we'll let you know of any feedback that we get.
Okay, amazing. Thank you so much.
Thank
Thank
Bye.
you.
Bye.
Thank you. Have a nice evening.
Дякуємо.